Good morning, everyone. You can hear me well. I hate using mics. I could probably just, the room's small enough that I could walk around and talk, but I'll try the mic. Let me know if you can't hear me, if I fade in and out, because that's the challenge with the mic, is you always got to, be at the right place. But thank you for being here this morning. I'm here to talk about the HDSA Federal Advocacy Program and kind of give you an introduction to, from your civics class to advocacy to Federal Advocacy 101 that you might have gotten from your civics class in 6th grade. But first, I just want to share that the HDSA Advocacy Program is part of the HDSA mission team. So I work underneath Eric Johnson, who is our Chief Mission Officer. The staff of the mission team supports the HD community in many ways, including working with the HDSA Center of Excellence Clinical Care Network, supporting over 100 social workers nationwide, providing support groups for people living with HD, providing assistance in the Social Security disability process, developing and presenting educational resources, directly supporting HD science and communicating research updates, and offering numerous programs for services for youth and young adults. So that's my opening script. You now know all about the HDSA mission team. But I'm here to talk to you today about HDSA advocacy. But first, I just want to, introduce myself to you. I know many of you, I have many friends here in the audience, but many of you don't know me. I've been with HDSA for 2 years. This is my 3rd convention. I started at HDSA. My 2nd week was convention in New Orleans. So that's how I joined HDSA. I always want people to know that I do not come from an HD family. However, I do want you to know a little bit about myself. Prior to working with HDSA, I supported the advocacy efforts at the Depression and Bipolar Support Alliance. I live with a mental health condition. I support family members who live with a mental health condition, and I can share with you that I have supported 2 immediate family members through suicide attempts. I also, my mother had elderly adult onset Parkinson's disease. So I supported her through that crippling disorder all the way through her living in a skilled nursing facility. So while I am not a Huntington's disease family, I want you all to know that. But I do have adjacent experiences, and this is why I chose to come work for the Huntington's Disease Society of America, because I felt that I could certainly help and support the community. All right, so we have a saying that we use with our advocacy leaders. I'm going to talk a little bit about our advocacy leaders program at the end of this session. But I also present at Education Day, so if any of you have been there at my Education Day, you are aware of this. But we always open all of our monthly meetings together, and you can imagine we do this on Zoom. So we have about 20 people on a Zoom call, and I always say it's my beautiful symphony to hear all those different voices on the Zoom call at the same time, reading our guiding principles. So I invite you, all of you today, to join with us. 1, 2, 3. We support family members in claiming their own power to alter the relationships of institutions holding power. Together, we create a string of wins in pursuit of our goal to improve the lives of everyone with HD and their families. All right, give yourselves a hand. I always love hearing that. All right, so like I said, today I'm going to talk to you about our federal advocacy program. But I think it's important to understand that, what type of advocacy I'm going to be sharing with you. So I'm recognizing that there's 3 different types of advocacy. There's self-advocacy. The fact that you are here, you are participating in self-advocacy. When you go to the doctor or to the clinics, you're participating in self-advocacy. When you are, helping your loved one get adequate care, or yourself to get adequate care, you're participating in advocacy. That's self-advocacy. There's also individual advocacy, And that's advocacy that rises up around and centers around an individual. Since we're in Indiana, I will use Ryan White as that individual. You know, Ryan White became the center focus around the HIV/AIDS program and the advocacy around that. And so when you have an individual that everyone rallies around, that's called individual advocacy. There is a book in an NPR that was from an NPR podcast called The Other Dr. Gilmer. I don't know if any of you are familiar with that, but that raised awareness around Huntington's disease. It was written by a doctor in North Carolina who came to take over a practice, and he discovered that the person whose practice he was taking over in this small town his name was Dr. Gilmer, and he was Dr. Gilmer. So he was curious about that, and he looked into and explored that, and he discovered that the Dr. Gilmer that he was replacing was in prison for a homicide. He had killed his father, and the man lived with Huntington's disease, and he was in prison and not getting adequate care. And so there was this awareness that he created and became an advocate for Huntington's disease around the other Dr. Gilmer. But I'm going to talk to you today about systemic advocacy. And that's advocacy where we go back to that guiding principle that we use our power to alter the relationships of those institutions holding power. So we can work together collectively to bring around policy reform, especially as it relates to improving the lives of people living with Huntington's disease and their families. So at HDSA, we deploy 3 pillars to achieve our advocacy success. The first one is to create awareness, and we do that in multiple ways. When you respond to action alerts, you're creating awareness. When you visit a member of Congress or their staff, you're creating awareness about a particular policy or issue of Huntington's disease. The other thing that we can do, and now you're saying, now we can't hear me. All right. You know, it takes a village, doesn't it? You know, that's great. I appreciate it. The other thing that we do is we drive the conversation. So many of you might be aware of our externally led patient-focused drug development meeting that we had last year. It's part of the FDA's patient-focused drug development program, where we brought in, we had over 146 members of the HD community at a meeting which was attended by the FDA and medical product developers, where the community shared what their experiences are around the impact of living with Huntington's disease and their perspectives on treatment. And it was a full day meeting, so we were driving the conversation. But I like to say that, you know, back in the old days, and I'm going to say in the aughts and the early 2000s, the goal of advocacy was to have a seat at the table and be invited to the table. We have progressed so far beyond that, and so has the HD community, because I say that it's no longer important to be invited to the table and have a seat at the table. We need to be setting the menu, because there's an old saying that if you're not at the table, you're on the menu. And so we need to be setting the table, and that's what I mean by driving the conversation. We're no longer waiting to be asked. We deserve a seat at the table. We've been at the table, but now we need to drive the conversation. And so the externally led patient-focused drug development meeting is a perfect example of that. A Voice of the Patient report, it will be published and sit on the FDA website. It will be available to researchers. It's available to the FDA when they review new drug applications. It's available to medical product developers. So they'll be able to read this report, and it's you, the community, that will have told them, this is what's important to me when it comes to new treatments and therapies. So if we do those two things, if we create awareness and we drive the conversation, we have the opportunity collectively to influence legislation and policy. So, you know, as my role at HDSA, I serve as a grassroots lobbyist, and most importantly, as a community organizer. My job is to organize you, the community, to create awareness and drive the conversation. So what are our key areas of focus around advocacy? It's to speed innovation in the development of new products, and we'll talk a little bit about that later, but clearly that patient-focused drug development meeting that we had in November was an opportunity to drive the conversation around speeding innovation in the development of new products. Increasing access to care. So there is a lot of ways in which public policy, federal policy, and legislation can be a barrier to care that we need to knock down, or that we need to support when it's, and encourage more access to care. And then also to reduce the financial burdens on HD families. So before I get into what is our advocacy, legislative, and policy portfolio, I want to take a moment here to help you understand how an idea becomes law. So we all, how many of you learned this in your 6th grade civics class? I know I did, but that was a long time ago. And let me tell you, I will tell you, a lot has changed since my 6th grade civics class. So I think that my 6th grade civics teacher would be shocked at what I'm going to be sharing with you this morning. So first thing you need to know is that any member of Congress can introduce a bill during a session of Congress. We just started the new Congress, the 119th Congress, on January 4th of this year. A Congress lasts for 2 years. That's it. And then it goes away. And you have a new Congress. So any bills that were introduced during the 118th Congress are now dead. If they didn't pass, they're dead. So they have to be reintroduced. And so any member of Congress can introduce. But once that bill's been introduced, it gets assigned to the appropriate committee. So the House has 20 committees and the Senate has 16 committees. In the House, because there's so many members in the House, they are allowed to serve on multiple committees. In the Senate, they're assigned to just one committee. Now, this is extremely important. Remember I said any member can introduce a bill. And that bill gets assigned to a committee. But it's the committee leadership that decides what happens to that bill. They're the ones that move that bill forward. So, that if you think about, depending on who's in power in the House, I'm just going to use the House, so I'm going to use in my example as the House. The majority member of the committee lead is a Republican, because that's who's in power right now. And then there's a ranking member that's a Democrat. And there's always more members of that committee in the party that's in power. So there's more Republicans serving on a committee than there are Democrats. So let's say Representative Foxworth introduced a bill, and she doesn't like and doesn't get along well with the head of the committee that bill's been assigned to. Do we think that bill's going to go anywhere? Probably not. So it's really, any member can introduce a bill, and we absolutely encourage our members to introduce bills. But I just want to give you a point of reference that it's important that when that bill is introduced, that they're building up a reliance with that, wherever that bill is going to be assigned, to that leader of that committee, the chair of that committee. So the chair decides whether or not the ranking member, the chair decides whether that bill is going to advance through the committee, have a hearing, have a markup, and whether it's even, and then it has to be voted out of the committee. So remember that there's always, the party in power has more members in the committee than the party that's not in power. So again, it would kind of be helpful if you're aligned with that party. Although there's still a lot of bipartisan work that goes on in Congress. But then so it has to get voted out of committee, and then that's still not enough. Even if it's voted out of committee, that chair decides whether to bring it to the floor for a vote. So you can see how difficult it can be just to even get that idea, to a vote. Then it has to go to the other chamber. So now it has to go to the Senate. And someone in the Senate has to introduce that same type of legislation. And 9 times out of 10, often not, it's not the same language. So the Senate has to go through the same process, and then they pass it. Now you've got 2 bills, and guess what? They're not the same. So now you have to conference and get those bills identical. And then they have to be voted on again, because now you have to vote on the same bill. So now you can understand why it takes so long for a bill to move. So for our purposes, there are two different types of committees. There's one that authorizes a bill, and there's one that funds a bill. So let's say that Representative Foxworth was successful in getting that piece of legislation passed that said that we wanted to have funding for support groups run by social workers. And we needed money for that. And that bill passed. And that will, just to show you there as an example, who are the committees where that bill could possibly come out of. In the Senate, it would be the Finance or the Help Committee. Help stands for Health, Education, Labor, and Pension. In the House, it's the Energy and Commerce Committee, and it's the Ways and Means Committee. So let's just say that, let's say I sat on Energy and Commerce Committee, and I got that bill, the House approved it, and I had a friend in the Senate who picked it up, and the Senate approved it. So there, aren't we done? It's great. No. There's got to be funding attached to that bill. So that bill might have said, we're giving $100,000 to HDSA for support groups run by social workers, but until another committee actually funds that bill, it goes nowhere. So there are appropriations committees that appropriate funding. And there's an appropriations committee in the Senate, and there's an appropriations committee in the House. So I think that that is your updated Civics 101 lesson, not to discourage you, but to help you understand why mobilization and why creating awareness and driving the conversation is so important. I'm going to go through the legislation that we have, that's in our portfolio for this year, but I do want to take just a minute to talk about Medicaid. So if any of you are been following the news about the political news, you know that there's the big, beautiful bill, and it passed the House on May 22nd, and it is getting kind of stalled in the Senate here, but the goal is to have this bill passed by July 4th. And I just want to share with you what is in that bill that could affect our HD community. So there are work requirements for people accessing Medicaid for their health care. And we all know that, we shouldn't say all, but many of us know that when people become disabled and are no longer able to work, they often apply for Social Security disability. And that process can take 5 to 6 months, and then there is a 24-month gap before they can have Medicare. So there can be like a 29 to 30 year, almost 3 years, where they are not able to work. But there are work requirements in this bill. And now it says that people who are disabled would be exempt. But if you haven't gotten that claim processed yet, you're not technically disabled, right? So there are work requirements in that bill. There are administrative burdens in that bill that you have to recertify every 6 months. So let's just say that you did get your SSDI, you are disabled. Every 6 months, you would have to recertify to continue to receive Medicaid benefits. And if you don't, you only have 30 days to be in compliant. Otherwise, you're disenrolled from Medicaid. That is what is in the bill, folks. In the past, states were allowed to put the home equity limit on people who were needing to access long-term care services. This bill takes that right away from the state. The states no longer have the right to do that. So certainly you can imagine in high income, not income, but in high living states such as New York, the East Coast, New York, Delaware, Illinois, where I'm from, Chicago, certainly on the West Coast, California, Oregon, that owning a home after 30 years that's worth $1 million does not make you a wealthy person. It may in some states, but in many states it does not. That's why it was a right of the states to set that limit. This bill takes away that right from the states. and the limit is set at $1 million. So you would only be able to have $1 million equity in your home and still be able to access long-term care services. It also has a $35 per visit copay. So you can imagine if you are on Medicaid expansion and you see how many visits do you see in a given month, that can add up very, very quickly. But I am here to say we need to create awareness. If you scan that QR code, it will take you to our to a page on the HDSA site where you can send an edible letter to your senator telling them not to vote for this bill. And I will share that there certainly have been some hurdles. If anybody wants to talk to me afterwards, I can talk to you about the hurdles that are happening with this bill. But the goal is to get this bill passed and on the president's desk by July 4th. So if you want to participate in advocacy, you can do that right now. All right, so now I want to take some time to talk about the legislation that we are tracking. So in innovation and developing new therapies, we're tracking the Ensuring Pathways to Innovative Cures, which is called the EPIC Act, and we're following the Orphan Drug Act. With regards to access to quality health care, we're tracking the Alleviating Barriers for Caregivers Act, the Telehealth Coverage Act, and the Expanded Telehealth Act. With regards to access to medication and Medicaid, we're tracking the RARE Act, the Help Copays Act, and the Safe Step Act. And then with regards to reducing financial burdens, the SSI Savings Penalty Elimination Act, and the Credit for Caring Act. So I'm going to go through each of these with you, break them down for you. So in innovation and development, the EPIC Act. So some of you might already, I'm not assuming that you are all policy nerds like me, so some of you might know this and some of you might not. But in the last administration, there was a big bill that passed with lots of things in it. And one of them was that the federal government could, CMS, the Centers for Medicaid and Medicaid Services, could start negotiating with pharmaceutical companies on the prices of drugs for Medicare. So that passed several years ago. But whenever there is policy, and I'm not critiquing anybody's policy, there's always unintended consequences that get written into a bill that somebody didn't see and that needs to be corrected. In that act, small molecules are available. Small molecules, think like a drug that you take by your mouth. They are eligible for price negotiations 7 years after FDA approval, and then it goes into effect 9 years. But biologics they get a break. They're not eligible for price negotiation for 11 years. So what research shows is that research has moved away from small molecules. Like, why would you not? If you were an investor, wouldn't you invest your money where you're going to have a longer time to recoup your return? So research shows that investment has moved away from biologics. So the EPIC Act, it gives a level playing field. It says, yes, whether it's biologic or small molecule, they all have the same pathway. The Orphan Drug Act, this is one, again, was written into an unintended consequence, but the investment in rare diseases, if you have a therapy that treats one rare disease, you are exempt from the price negotiation. But if it treats more than one rare disease, you are not. So again, these bills are really lengthy, and language gets thrown in there, someone doesn't see it. Like, how ridiculous is that? Because let's just say that, my mother had Parkinson's and someone else here has Huntington's disease, and let's just say that there was a new therapy that treated both. Well, again, as you are an investor, are you going to make that product available for both? Because once you do, now you are exposing your investors to price negotiation. So how ridiculous is that? And we certainly know that probably was not the intention of the bill. So the Orphan Drug Cures Act corrects that problem. It was in that reconciliation package that passed the House. The Senate stripped it out. So again, write your senators and tell them put it back in. All right, the RARE Act. So now we have the new therapies, but they're not affordable. We can't access them because we can't afford them. And the RARE Act has language that says that CMS, the Centers for Medicaid and Medicare Services, can use additional resources to understand, to make decisions about making whether or not to make a new therapy available. And it also tells requires private payers to create an expedited review process so that that private payer can't say, oh, sorry, we're not going to cover that, it's too expensive. So that's again, having new therapies is great, but if we don't have access to them, what was the point? The Help Copay Act prohibits the use of copay accumulators. Now that's a big word, big fancy word, but many of us see the commercials on TV that say, if you can't afford your medication, contact AbbVie, we can help, because they give a coupon. Or they'll say, your medication might be only $25, just contact us. It's because they give a coupon to the individual to help pay, so that medication costs $500, but they get this coupon that says it's only going to cost $25. So guess what? You saved, help me with my math, someone, $425? Oh, $475. Did I say 500? Thank you. That's good. So Joyce knows. She has to double check everything Phyllis does. So what does the copay accumulator scheme say? Those pharmacy benefit managers say, no. You don't get to receive the benefit of that $475. You had a $500 deductible. Guess what? You still have a $500 deductible. You can't apply that $475 to your deductible. Or let's say you have a maximum out-of-pocket limit. Let's say your maximum out-of-pocket limit was $2,000. Now you have a, help me Joyce, $1,975 because we're not going to apply that $475 to your limit. So this legislation would help get rid of that scheme. The Safe Step Act is if any of you have ever experienced step therapy, where those pharmacy benefit managers will say, you can't have access through us. We're not going to pay for the medication that you and your prescriber think is best for you, but you can have this one over here. And you have to fail on that one first. After you've tried these three that we're saying you can have, then we'll let you have the one that your doctor and your prescriber say you should have. So I'm not asking for a show of hands, but I bet many of you have experienced that fail first strategy. And again, this is all means in which the pharmacy benefit managers can save money. And so but it's denying access to the community to medications that they should have. So the Safe Step Act has language in there that would help eliminate some of that. The Leaving Barriers for Caregivers Act. So if many of you, as you apply for those benefits through CMS, so does everyone know what CMS is now? The Centers for Medicaid and Medicare Services? All right. So as you apply for benefits through CMS, it could be for Medicare, Medicaid, it could be through anything, other Social Security Administration, SSA, Social Security Administration. Let's say you're applying for that disability. There is so much paperwork. I just applied for something through the FDA, and it's like, dang, I just did that paperwork wrong, and now I've been pulling my hair out for 3 days trying to figure out how do I get the paperwork back and change it. So we all know what a headache that is. And it can be time-consuming, and you can fill it out incorrectly, and it's a barrier to care, right? So this act requires that the SSA and CMS take a look at their forms and analyze them and make them easier and less time-consuming and easier for people to fill out. The Telehealth Coverage Act makes permanent the telehealth flexibilities under the Medicare program. So during COVID, Congress passed a law saying, we don't want you going to the doctor. You can see, we're going to have these telehealth visits. So how many of you now have telehealth visits and think they're a staple? I know I do. I instead of going to the doctor, instead of going to my oncologist, I was a survivor of breast cancer. I don't need to see that oncologist every 6 months in the office. I just do a telehealth visit. And those are not permanent. There was a time ending on that. Like with a lot of legislation in Congress, thankfully, a lot of the legislation, most legislation is not permanent. There's a time ending on it, and you have to reauthorize it. It's not been reauthorized. It's been extended. And I cannot tell you the number of emails I was getting last December from your directors of the Centers of Excellence saying, Phyllis, this is going to expire. What are you doing? What are you doing? And it's like, what are you doing? You know, are you writing your senator? Are you writing your representative? Phyllis can't do anything, but you can. So it was extended, but it expires in September. This legislation would make it permanent. There's also an expanded Telehealth Access Act, which would allow things like physical therapy and occupational therapy to be done by telehealth. Now, how great would that be? You know, you didn't have to drive to the clinic to get that OT. You'd have that therapist on screen with you and helping you, and wouldn't that be an easier way to access care? So those are those are the 3 pieces of legislation we're tracking to increase access to quality care. And the last one here is to reduce financial burdens. The SSI Savings Penalty Elimination Act. This, right now, in order to continue to receive Social Security supplemental income, you have to have resources under $2,000 for individuals or $3,000 for married couples. Now, that's not a lot of money, is it? And I can tell you, it's been decades since this has been upgraded. So there is the legislation to change that to $10,000 for individuals and $20,000 for married couples, and to adjust with inflation. So that would be very, very helpful. And then the Credit for Caring Act. So this allows a caregiver a tax credit, not a deduction, an actual tax credit of up to $5,000 that they can deduct from their taxes for 30% of the cost of long-term care services. So again, that would be a big help to families that are supporting a loved one. All right, so that is the legislation that we are tracking. And how am I doing on time, timekeeper? 27 minutes, wow, all right. Okay, so why did I tell you all of this? Because one of the campaigns that we have is our August recess campaign. This is, it all couldn't fit on the headline there, and it's a mouthful, but it's the HDSA August Congressional Recess in District Meeting Campaign. So your members of Congress go home every August for the month. And let me tell you, that's what, this is a sidestep, that's what we're trying to prevent with this reconciliation package. If we can delay it past July 4th, because they're all going home for July 4th, and then they come back, and if we can keep it in, keep these barriers up to getting it passed, then they go home for August. And guess what? That package that had that Medicaid in there never got passed. That's why it's so darn important to keep the pressure up, because if we can make it past July 4th, we're a little closer. We might be on third base. We're not home yet, but we're on third base, because then the August recess happens, and August Congress shuts down. They come home. That is the best time to meet with your member of Congress or their staff. So I always say that fly-ins are great, and they're great, and they're energizing for the community, because they get to come to D.C. and they get to walk the halls of Congress, and that is wonderful. So let me tell you an example of setting the table. My first year here, in October, we had a congressional briefing with the 2 other organizations, the Tourette's Syndrome and the American Foundation for Suicide Prevention, and the topic was suicide prevention in chronic diseases. And it was in October. And a congressional briefing is where the outside external organization comes in. You've all seen the briefings where Congress subpoenas people, and they come in, they sit at the table, and they look down at them and ask them the questions. A congressional briefing is where the outside organization comes in, they invite members of Congress to come to their briefing. And it's always, in order to do a congressional briefing, you have to have a member sponsor it. And so we had this congressional briefing in October, and we were very concerned because the government funding ends on September 30, and there was they had not passed a budget, and we were very concerned that the government was going to shut down, and what was this going to, and there's Christine in the back there. I know she was one of our advocates, and she kept contacting me every day. Should I make the area? Should I go? Should I go? And I'm like, well, we're going to try to go. But guess what? The government got funded, but that's not what the issue ended up being. They had to have the Speaker of the House got kicked out, and the Republican Party had to vote in a new speaker, and everything shut down because they didn't have a Speaker of the House. And this was going on the day of our congressional briefing. Now, we still had people come, and it was, but it was slight. But what was most important to me was that I walked around the halls, because they held the congressional briefing in one of the offices. I walked around those halls, and I saw all those people in their red T-shirts. And I said, you poor souls, because ain't nobody interested in talking to you today. They don't care what your issue was. They got bigger problems on their hand in that they don't have a Speaker of the House. And so I'm not necessarily a strong advocate that fly-ins are the best way, because you have no idea what's going to happen on that day. That's going to pull everybody away and pull their attention away. August, they got nothing going on except to meet with you. Go to their town halls, schedule meetings with them. So if you come to our session tomorrow, and I realize that we have some stiff competition tomorrow, it is the last session of the day, and it's up against the Ask the Researcher. But if you come to our session tomorrow, we have advocacy leaders who are going to be on a panel talking about how they advocate, why they advocate, and they're going to give you more information about the August Recess campaign and how you can get involved in the August Recess campaign. But you can scan that QR code, and it will take you to our HDSA advocacy page, where you can find all kinds of information about our August Recess campaign. There's training materials on there. Last week I gave a webinar that will be, it was like a 40-minute webinar. It will be up there on that resource page shortly. And the presentation that I gave was up there, but all of that legislation that I just reviewed, that's up there with the explanation of it. But most important, there is a tab there, there's a link there that says State Captains. So many of our advocacy leaders have volunteered to be state captains in their state. And so they are there to help you. They are there, our state captains will be setting up those meetings with the senators' offices, and they want you to join them. They will be setting up meetings with their representative, and they will help you and set up meetings with your representative and coach you through how to do that. So you're not alone, and we have if you're interested in any of that legislation that's in that portfolio, we can talk more about how we do that tomorrow at the 4 o'clock session. But in the meantime, if you want to scan that code, you can find the resources and find more information. All right, so again, there you can see that this is our home page. You can scan that, or you can type in that URL, and that takes you to the Advocacy Hub. That's our home page. And you will see those campaigns on there. Schedule meetings with your members of Congress at home during August. You could click on that if you didn't scan it. You will also find there the campaign to email your senators. So you can find that there as well. So it's pretty easy. Just go to the HDSA website, go to the Advocacy Home, and take action. You can also subscribe there. So when you're out there, there's a place where you can subscribe to the Advocacy Hub. And again, when you subscribe to that, you will get bi-monthly newsletters from HDSA specific to advocacy. There's a newsletter called Take Action that talks about what we're doing in the area of legislation and policy around pretty much access to care, and you will also receive action alerts. The other bi-monthly newsletter is called Drive Change, and that focuses on what we're doing to speed innovation in the development of new therapies. So when you subscribe, you will automatically receive those communications from the advocacy department. We also have an advocacy leaders program. So if you're an advocacy leader, can I ask you to stand up? So we have advocacy leaders in 17 different states. And these are people who have shared that they want to do more. And trust me, everything you do is important. But every time that you respond to that action alert, every time, those of you who are going to email your senators, that's important. So please do that. But these are individuals who said, I'm ready to step up and do a little more. And they come to Chicago once a year to get a day-and-a-half workshop on, they learn about the legislation, they do role-playing on how to hold meetings with their members of Congress or their staff. They support each other. We have monthly calls. The third Wednesday of every month, we do 2 calls to support people's times. We do one at 5:30 Eastern time and one 5:30. No, it's 6:30. I'm sorry. It's 6:30. I can see that look over there from the people who keep me honest. It's 6:30 Eastern time and 5:30 Pacific time, so people can join whenever they want. But they support each other. Many of them have volunteered to be the state captains for their states to help with this August recess campaign. So everyone is invited. All you have to do is just email advocacy@hdsa.org and say you're interested in the Advocacy Leaders Program, and I will put you on that distribution list to get the emails for our monthly Advocacy Leaders meetings. And I just want to share that people step up when they are able. People step back when they need to. And there's never any pressure from anybody to do more than you can do. It's an opportunity for you if you feel it's the right calling for you. And you can attend the advocacy leader calls and say, this is enough. This is all I want to do is be informed every month and be around other advocacy leaders. That's okay too. So again, I just want to continue to emphasize that it's whatever you're comfortable with at whatever, wherever you are in your life at any given moment. People step back, but then they re-engage when things change in their life and they feel like they have more time. So it's a very, very flexible program. There is no long-term commitment. It's there for you. And that's really the main thing that I want to say. It's there for people who feel that they can really benefit from taking on this role. That is all that I have. I'm open to taking any questions from the audience.
And if you have any questions for Phyllis, let me bring the mic around because we're live streaming. I want to hear what the questions are.
I'm pretty confident that the big, beautiful bill will not be approved by my senators in my state. So how can I advocate in other states? Is there a way to do that?
That is challenging because I just had this conversation with someone this week. And I said that I honestly will tell you, I honestly believe that over 90% of your members of Congress are there because they want to serve. Now, we may all have different ways in which to get to, that's the difference in the political ideology, but I honestly believe that they care about their constituents and they are there to serve. Now, there might be some that have the limelight, but that is my honest belief. So, having said that, your member of Congress is only interested in talking to a constituent because they're being inundated with all kinds of people, right? They represent thousands and thousands of people. So they don't have time for you if you're not a constituent. But you can certainly reach out to your senator and say, hey, can you, like this person was saying that they lived in an adjacent small state. And I said, he thought, well, it would be appropriate for me to reach out to my senator and say, hey, can you talk to that other senator? I said, absolutely. And I think that's how you can best do it. You know that what your senator is going to do, but you can write them and say, I would really appreciate it if you could do a little research. You know, maybe there's someone that you know, like, oh, they get along well with that person, and ask them to support. You say, hey, can you contact your colleague and see if you can get your colleague to support, or share my story. You know, share my story with your colleagues.
And I saw lots of hands, so I'll get everybody.
Besides the big ugly bill, have you found any recent things that have been impacted with funding being diverted or being eliminated elsewhere?
No, because quite frankly, everything's being taken up by the big beautiful bill. So there's not, I mean, with what you saw on the slide was, if there was a number next to it that said S or HR, those bills have been reintroduced. So there is some work being done, but really most of the work will get done after this happens. You know, either it won't happen and September will come. And the problem is we now have to work on the 2026 budget because the government ends on September 30 and we don't have a 2026 budget. So the unfortunate truth is that it's not just this Congress, it's been going on for a long time, for over a decade now. We run this country on continuing resolutions. And what that means is they say, okay, we're just going to keep funding the government at the same level we've been funded for the next 3 months and kick this down the road. And then it comes up again. It's like, okay. So that's what we've been doing since last October 1st, is just running the government on a continuing resolution. So it's challenging times to get anything done. I was here at the last Congress, the 118th Congress, went down in history as the Congress with the least number of bills ever passed. And I don't see that changing.
Hi, I'm Tom Long, Cincinnati chapter. Great presentation. I was wondering if you had an update at all. A few years ago, I participated as a volunteer on the Parity Act campaign. Mm-hmm. And I visited with my congressman and my senator, along with all the groups of people in a coordinated campaign in D.C. And I was wondering, whatever became of that? I mean, we were gradually accumulating yes votes. And I don't know whatever happened to it.
So remember, going back to how a bill becomes law. You could have, there's 465 members of Congress. You could have 400 co-sponsors of people who said, yeah, I'll co-sponsor that, because there's no skin off my neck, right? I can co-sponsor something that doesn't hold me accountable. That's not the same as a vote. And I think that's really important for people to remember. That there was this enthusiasm that, yes, my representative co-sponsored it. Why not? There's no harm to that representative co-sponsoring it. That does not mean that person was going to vote for it. And it wasn't any risk. There was no risk to them because they knew that bill was never going to come to the floor. And that's the challenge. That's why I think it's really important to understand anybody can co-sponsor a bill, anybody can sign, anyone can introduce a bill, anyone can co-sponsor a bill, but it has to go through all those steps to get to a floor vote. So when your representative says they'll co-sponsor a bill, we want them to do that. But just know that's not the same as saying, I'm voting for the bill. So right now there just isn't, there isn't. Just so you know, every bill that gets introduced in Congress gets scored. And that's like 25 years old, that the CBO scores it. And if a bill is going to cost the federal government money, it gets the highest score. And it is very, very, very rare that a bill that's not scored 0 ever makes it pass. So that's the challenge with the parity, because it will receive a score. It's going to cost the federal government money. So that's the challenge. So I'm just giving you the realistic realism, and that's why there's no movement on it at the moment.
Hi, my name is Kelly, and I'm from the Tampa area, and I would like to get involved in the advocacy, and I'm currently involved in the legal profession for the last 25 years. And I want to thank you for the breakdown that you gave with regards to how these pass. And so I have some basic statistical questions. How long does a bill actually take, typically, on average? How many bills make it and don't make it, on average, if you have any of those?
So I do not have the answers to that last question, but I know that I took 13 years ago when I started doing this work for the Depression and Bipolar Support Alliance, I took an advocacy training from the National Council of Wellbeing. And I was told that it takes 16 years for an ideal to become law.
I'm going to go a place that
So, but this is not to discourage you folks. You know, come on. No, this is the reason why you need to get involved.
I'm going to go a place that Phyllis won't or can't, because we all know we have the difference in our elected officials between Republicans and Democrats. In my case, I have a representative who is a Republican. She's going to vote for the big, beautiful bill. I can guarantee you she will, okay? No matter what I do, no matter how much I lobby her, and believe me, I lobby her. However, she serves, Phyllis called me out on this in Chicago. She serves on the Rare Disease Caucus. That means she's going to hear about my rare disease concern. So even if you've got a representative or a senator that you already know how they're going to vote on something, it doesn't mean you shouldn't still contact them about your concern with people with Huntington's disease, because there's a whole segment of those people that are serving on caucuses or other committees that they're still going to listen to you. Thank you.
Who else? Let me get one on this side or this side. Maybe.
My name's Wes Johnson. I'm with the Michigan chapter. Can you explain a little more about the work requirements that this bill, the wonderful bill, is going to provide?
So the reconciliation package that passed the House, that's now sitting with the Senate, does have work requirements to be eligible to receive Medicaid benefits. And it carves out people with disabilities, and it defines that. But you'd have to be certified that you have a disability. So if you have a disability, you would not be required to work. However, and this is the big however, you have to recertify every 6 months.
What do you mean recertified?
You would have to, every 6 months, you'd have to prove that you were disabled.
How do you do that?
Well, your state, so the state, so the federal government funds a large chunk of Medicaid, so do your states fund the other chunk, but the states are responsible for administering Medicaid. So what this is telling the states, you will have to set, state of Indiana, a process in place so that all the individuals who are receiving Medicaid can certify that they are working or that they are exempt. And they will have to, you state of Indiana will have to set in place a process so they can do that every 6 months, because if they don't certify every 6 months, you state of Indiana must disenroll them.
Hello, I'm from Nevada, and the question, as some of the other questions, definitely this involves Medicaid. The big concern in our state is the waste, fraud, and abuse of Medicaid, where people who don't deserve it are getting it, and people who do deserve it are not getting it. So is that something that you recommend, Phyllis? This was an outstanding talk, and I'm proud to be on your committee. But should we broach that in our meetings with our congressmen?
Well, you could, but what I always advise people is that if you try to get into a policy discussion, we have a policy firm. We tag team very well together. I come in and I tell the HD story and represent HDSA. She comes in and talks the policy. Because as soon as you get me into a policy conversation, I'm going to lose. But they hear my story, and they hear the story that I'm representing all of them. I shouldn't say my story, it's not my story, it's your story. I'm bringing forward your stories, and that's what they care about. So my recommendation is to share your story as it relates to some of those issues. It could be work requirements, it could be the $35 copay. Just talk about heartfelt, because I go back to what I said, I do believe that 90% of our members of Congress are there to serve. They feel they're doing public service. They care about their constituents. So if you share your story, I think that's the most important thing.
Thank you very much, Phyllis, and I just appreciate your work for HDSA. It's just incredible.
Well, you're welcome.
We still have a few more minutes for more questions, so if anybody else has any, I'll go in here.
I just wanted to follow up on something from what this gentleman was saying. So my understanding is that once a person is declared disabled by Social Security, that they are automatically eligible for Medicaid. In Florida, I
Okay,
believe
so like I say,
that's,
it's different every state.
I know, and that's the confusing part. So in Florida, they would not, currently, my understanding is they do not have to requalify. They wouldn't have to requalify. The assets and income, yes, but not the other information about whether they're disabled or not. Do you see where I'm going with
So it
this?
depends on whether you're talking about SSI, Social Security Supplemental Income, or Social Security Disability. Social Security Disability is, you worked your whole life, and actually you worked, you put in the work history, and so this is kind of like an insurance plan. Now I get to take the money back out. But all I'm saying is that the law, what the new law would be, they're telling the states. So in other words, they're taking away some of the rights of the states to administer Medicaid the way they have seen fit. They're creating a standardization that says you no longer get to have these waivers, state of Florida, to do it your way, or state of Indiana. We are telling you this is the way moving forward it has to be done.
Okay. And just a little more follow-up to that, for people, say, who are on SSI who get maybe $900 or $700 a month, a $35 copay, if they're not able to afford that, does that mean they're going to go without medical care? Do we know what that's going to look like in future?
And I also just want to share with you something that I have not brought up, but that I think it needs to be said, that it affects all of us. Even if you are not a Medicaid recipient. I mean, I'm just going to speak strictly of for example, Lurie's Children's Hospital in my hometown of Chicago. 60% of their revenue, they're a premier children's hospital, 60% of their revenue comes from Medicaid. So all that 40% that are private pay, guess what? It's not going to be there because they've lost 60% of their revenue. Rural hospitals are going to close, because rural hospitals have a huge percentage of their revenue is coming from Medicaid. So if that revenue is not coming in, that hospital can't stay open. It's going to drive the prices up of your private insurance. So we are all going to be affected by this. It's not just the people on Medicaid.
I think that might be about all the time we have for questions at this point, so we're right about 10:30. So.
All right, thank you, folks. And